And without further ado, Dr. Tan will introduce our first speaker.
All right. Good morning, everyone. So today our first speaker is Dr. Praveen Mummaneni. I think he really needs no introduction. He's our endowed professor of neurosurgery and also surgeon lead of the surgical triad, which represents all the surgeons at the UCSF and advocated for us. So many hats, very busy surgeon, and have done quite a bit in terms of researching minimally invasive surgery. So he's going to give us an update on the techniques and outcome.
Thanks so much, Lee. Thank you also to Lionel. Thank you to Sari for helping organize this course. I also want to thank my research team is sitting in the back, Alicia and Vivian and the fellows for helping me put these cases together. I have disclosures which are here. So this paper, I think in 2020, has been one that's been frequently used when you decide on which cases you want to do MIS deformity correction. It's from the ISSG, the minimally invasive subgroup. Basically, the algorithm is like this. You can do really easy, straightforward cases MIS. You can do moderate cases MIS with some LLPI correction needed up to 30 degrees. You start getting really big curves with old hardware, you're going to end up opening it. And we see plenty of those at our shop too, but we see a lot of these class 2 and class 3s, and I'll take you through some of those. Then another question I often get is, should I do a lateral? Should I do a T-lift? Should I do an A-lift? And so the same group made this interbody selection algorithm, which one to choose at which time. And basically, it's based on the level. These are the levels most commonly operated. 5-1, if you really want the lordosis, there's nothing to beat an A-lift. 4-5, you can do a T-lift, but it's not going to give you lordosis. That's why the red lines are there. If you really want lordosis at 4-5, you either got to do a lateral or an A-lift. You can decide whether or not you want to section the ALL. And then 3-4, the vast majority of folks in this subgroup or in the MIS ISSG subgroup were doing laterals. So, and then the other question that comes up is, who's a candidate for this, and can everybody do this kind of surgery? There is some gradation. The more severe the deformity, the more we're trying it in some of these patients, but it's challenging. You really get these really high LLPI mismatches. You can do it, but it takes a lot of effort and it takes a lot of experience to do, but these sort of easier ones are pretty straightforward to do. But the other thing that we pay attention to when we select these patients is we have to look at their psoas anatomy. If they have these Mickey Mouse ear psoas, you really don't want to do the laterals. How much spinal stenosis do they have? You can get a lot of indirect foraminal decompression by doing A-lifts and laterals, but sometimes I still have to open the back a little bit with the tube and take off the facet joint in order to decompress on some of these really critical stenosis. Some of these have pre-existing fusion. Many patients have osteoporosis, and at our shop now, the ortho and neuro folks are working very well with the endocrine folks to try to identify the osteoporosis and treat it with teriparatide or other medications before we ever get to the OR. And then you have to think about BMI. Not such a problem in Northern California, but it is a problem in other parts of the country. So a couple of cases. This is a typical patient that I'd see in clinic, between ages 65 and 75, with a moderate LLPI mismatch at 24, and then has this coronal curve. And of course, anybody who has this kind of coronal curve, on the concavity of that curve, they will often have the foraminal stenosis. So this would be classified as a class 2, a moderate deformity. If you need lordosis and 5-1 is involved in the fractional curve, then A-lift is a nice way to go. You can also do laterals. We can do our A-lifts in the lateral position, which was done here. Basically a lateral to 4-5 and then a lateral position also to 5-1. And then if you're in the lateral position, you can also put the screws in the back at the same time in the lateral position as well. We use a lot of navigation. This is one of our chief residents, putting the screws in from the posterior percutaneous fixation with the patient still in the lateral position. So by doing that, you are minimizing your time for flipping, and you are obviously not losing too much blood. So, these patients do fairly well. We don't usually, have to give any blood transfusions or anything like that. We don't need ICU stays for them. And you can get, this was a correction of the fractional curve. You can get the fractional curve correction reasonably well. And we try to do these curves and try to figure out which one has symptoms from the fractional curve, which one has symptoms from the main curve. And if you can keep yourself to the fractional curve, it's a lot less surgery for these folks who are, getting around the age of 70. Here's another one, another 66-year-old, and you can see this one has a class 2 also, and you can see that there's a lateral listhesis in the mid to low lumbar spine. You have a LLPI mismatch, which is not terrible here. More your issue here is the coronal cob is 30, and you have up and down foramen stenosis on the concavity of that curve. And here's one where if you don't really plan it correctly, you can throw this patient off in the coronal plane. And so you have to think about that as well. I like to stage these. So, I do the anterior or the lateral first, and then, I let them get up. We do an x-ray. We see if we're going to be tossed to one side or the other, and then we can correct for it in stage 2. So here's the coronal CT on this patient. And you can see the concavity has foraminal stenosis at multiple levels. And so we did, for this patient, a combination of lateral and ALIF. And then the next question is, do you want to do it in 1 day or you want to do it in 2? My typical practice has been to do it in 2, but we did look at this through the study group as well. And there's similar clinical outcomes, whether you do it in 1 day or whether you do it in 2. But the advantage of doing it in 2 is that you can get the x-ray in between and see what more correction you need. You can also get an MRI in between and see if you got enough indirect foraminal decompression. So this patient had the laterals and then had the PERC screws placed on another day. The question also comes up, should I stop my construct at L2? Do I need to go up to the TL junction? Can I even stop my construct at L1? I have not been taking all these patients up across the TL junction. I try to keep them in the lumbar spine as much as I possibly can. When you do the PERC screws on the back, you're not really opening up all the muscle window, so it hasn't been terrible in terms of PJK. Sometimes I will extend up a little bit. Like this one, I extended up to T12. I put a little cement through the screw. But I try to, I did that this time because it was, the end of the coronal cob. But many times I'll try to stay myself into the lumbar spine, L2 down, and keep myself, from crossing the junction. And even this patient, there's no ICU stay. There's no blood loss really from this operation. The lateral, multiple levels and the ALIF can be done in 1 day. The ALIF, our vascular surgeon usually helps us for that. And then, for the rod passage, and this is a question I get, the spine is curved. What are you going to do with the rod? Essentially with the percutaneous screws, the beauty of it is they've got long tabs in. So once you have long tabs in, and you can basically reduce the rod into the screw head, and it pulls the curve straighter as you do it. And so it's a matter of rod contouring. And then letting the spine come to the screw through the reduction tools. You can put them in. That's putting in an iliac screw MIS as well. You can just see the amount of blood loss there was not very much at all. And so this was a case where we did it for this patient who had basically a terrible flat back. Every disc is terrible. This person's 79 years old, is not going to tolerate a whole lot of surgery. And so we did a combination of lateral and ALIF for this person, and then PERC screws on the back. You can see this person is coronally malaligned, is sagittally malaligned, and at the age of nearly 80, yes, you could do an open front back for this, or just some really large surgery. But this is a pretty frail patient, and because the patient is frail, try to do the surgery with a lot less surgery. This one ends up in a class 3 because what you have here is lumbar lordosis of 19, pelvic incidence of 49. So a pelvic incidence of more than 50. So you need to get a lot of correction here. But with the combination of lateral and ALIF, you can get that. And then, we do put the iliac fixation at the bottom. And then, so we started here and we ended here. And you can see the coronal realignment. You can see the sagittal realignment. It's not perfect, but it's pretty good for someone who's nearly 80. And, again, no really big blood loss, no ICU stays for this patient either. So what happens with these people over time? And, we did start following a lot of these patients and comparing open and MIS through the ISSG, and we started propensity matching. And what we found out was basically intraoperatively, you do fuse more interbodies. You do lose less blood. The operative time is not too dissimilar, but if you're using stage surgery, obviously it's a little more than if you did it all in one day. So here's one more case. This is a 68-year-old with back pain, lateral leg pain, and then has the concavity of the bottom of this curve is not good at 3, 4, 4, 5, 5, 1. So it's a fractional curve issue. Again, trying to figure out what does this patient need? Yes, there's a main curve. Yes, there's a fractional curve. Is the pain coming from the main curve? Is the pain coming from the fractional curve? Where's the radiculopathy coming from? And doing some injections can help you figure that out. This one has a LLPI that's pretty matched. It's more the concavity of the fractional curve that I think is a symptom. We have a nice EOS machine that can help us get all these measurements, and we'll pay attention to these and put it into our surgical planning. And you can see the bottom of the spine is not looking great. 4-5, or I guess here they're calling it 5-1, it's a transitional level, is not in good shape. Trying to get some of these angles is sometimes not easy. This is the coronal portion of the lower curve. And so this one would be a class 2. You don't need a lot of LLPI, but you can see this is going to be more challenging class 2 because of the amount of coronal curvature there. So we did anterior for this and then a posterior MIS. That was able to get us some nice distraction of the foramina. And then even with that, there wasn't enough decompression. And so when we do the intraoperative CT spin for the stage 2, I still saw that there was compression of the right 5-1 and 3-4. So I dropped the tube down and did decompression there. And then we ended up like this for this patient. And, these cages really do a nice job of indirect decompression, but sometimes it's still not enough. Sometimes you still need to do a little bit of direct decompression with the tube. So this is where we started. And then, we wanted to make sure we didn't throw this patient off, and we didn't. The CSBL is pretty close to neutral, and this is where we ended. But you got to watch that CSBL and make sure you don't pitch these patients off one way or another coronally. So I'm going to stop a little bit early and leave some time for questions. We've done a lot of publications through the ISSG looking at this kind of stuff. You can't always reach 2-to-1 in one approach. Usually you get a combination of ALIF and lateral. You got to think about when you want to really cross the TL junction. You got to think about pitching patients off coronally if you do a lot of laterals, and staging them is one way to help to make sure you don't lock them into some unusual coronal, decompensated position. I think the MIS techniques are continuing to advance. When I think about these cases, I try to divide them up. Do I need to do moderate deformity correction? Is the problem more coronal? Is the problem more sagittal? For 2 to 4, I love to do laterals now. For 4-5, I sometimes do an ALIF or a lateral or a TLIF. It's kind of dealer's choice depending on how much lordosis I have and what the position of the psoas muscle, if it has Mickey Mouse ears or not. And for 5-1, there's absolutely nothing to beat the ALIF with lordosis restoration and the foramen decompression. So I'll stop there. Thank you. Hey, Joe.
Just the questions about the unilateral iliac fixation. Do you have a rubric in terms of which side you choose to place the unilateral iliac fixation, especially for those bow type C curves, let's say? And then do you have a long-term follow-up?
Yeah.
On those?
So, we started doing that unilateral iliac fixation. Actually, did a paper with SIG, I don't know how many years ago on that, and found out that if you had basically an ALIF at 5-1 and you had one screw, it was pretty much just as good as 2. Where you got into trouble is if they had really bad osteoporosis or they had a super high sacral slope. Those are the ones where, there's a lot of stress there. I typically will put the screw on the concavity of the major curve, because if you just look up, that's where the balance of the load is. So that's usually where I put it. And over time, I see some of these loosening. A few of the patients do have SI pain. If they get SI pain, we can always do an RF ablation, or rarely we come back and fuse the SI joint, going lateral to medial MIS. That's been a minority of patients. So nothing is perfect on these folks, but it's worked out for the most part, and it's a lot less work to try to secure those rods. Hey, Shane. Yeah, I think that's a good question, especially, you get on the concavity of the curve, those heads are really close together. It's hard to fit a connector in there. So I usually do use connectors if they PJK. What I end up doing is we'll open up, the top part of the incision, and then I may have to take out a screw and put a connector on one side, take out not at the same level, but another screw and put a connector on the other side. Or sometimes, because one side is on the convexity, I can fit a connector there. But usually I use connectors and run them up. Typically, because I have an inner body at basically every level, I don't get pseudos. So the problem is the PJK or the adjacent segment disease. And using the connectors is the way I get around it. One other thing that you could do is you could put also an extra iliac screw and then run an accessory rod and domino connect off of that on one side if you really had trouble securing. But usually I don't have to do that. Thanks, Nick.
Yeah, I was kind of terrific job talking. Is your leadership in really defining the appropriateness of MIS versus open, and the fact that you're one of the people who actually spans both. I think that's really important to emphasize, is the fact that you have the ability to do both and often do. I wonder, I'm sitting next to Steve here, who's a big advocate of multiple rods, and I look around the room and I just see Shane and Alekos and Joe and all these people who routinely put in 4 rods. And how's that fit into the MIS work? And is rod breakage a problem here?
Yeah, rod breakage has not been a problem here, and it's because I basically have an inner body at every single level. So the inner body is taking the stress off the rods. So it's not been an issue for me. And I usually will use those inner bodies with, man-made bone substances. And so the fusion has been fairly solid.
I agree. As you know, a big advocate of good inner body work. Kind of helps protect the rods.
Yeah, I think where people get the rod fractures is, you get a pretty aggressive osteotomy correction, and then you have no inner body support, and then the stress of the rod is high, and then you get the fracture right at the osteotomy. But because all of mine really don't have any 3-column osteotomies, they're all inner body supported fusions, so that it's not been an issue.
I've had actually some broken rods, even with a solid fusion, but most of them have not had interbodies at those levels. So with single rods on both sides without protected interbodies, I've had some fractures, and I've also had some fractures from SI joint suits or not fusion. So I had to change a bit of my practice for more aggressive distal fixation and SI fusions.
Yeah, I think nothing ruins your results like follow-up.
Yeah.
And then patients always find a way to fall down or, have some other issue. So, my stuff is not complication-free. I bring some folks back, but it's been a minority. Yes. Oh, sorry. Yeah, that's a great question. How do I avoid the malalignment of the coronal plane, especially when I do the fractional curve? And so this is why, we do a lot of intraoperative planning. And on multi-level cases, sometimes I'll stage the front and the back, and I have them stand in between and get a 36-inch scoli, and I'll see, are they leaning one way or the other? When I do the backside, I can do, compression or distraction as necessary to correct that. But you do really have to pay attention to that. And some of these bow curves, you got to really be very careful of throwing them off coronally, because you throw them off more than 3 centimeters, they're unhappy. So if I really get worried about it, I'll stage the 2, and then I look in the middle with the scoli X-ray and just make sure that I'm doing the right thing in order to get them to be aligned. But yeah, I do pay a lot of attention to that when I do the fractional curve. Great. Thanks, guys.